Welcome back to Hematology. Today we are going to embark on learning about primary hemostasis. This presentation will be an introduction to primary hemostasis and some platelet interactions. So mostly we'll be introducing the big players. We have a second presentation that will get more into detail about platelet disorders. So bear with me if some of these presentations have duplicate information, but you guys know how much I love a recap. So hopefully just hearing it more than once will keep it fresh in your memory. And speaking of recaps, here is another overview of hemostasis with a little bit more information about thrombosis added in. So as we know, the maintenance of circulatory hemostasis is achieved through the process of balancing bleeding or hemorrhage and clotting, thrombosis. Hemostasis really means the arresting of bleeding or the formation of clots, which we did talk about in our introduction to hemostasis prior to our secondary hemostasis lecture. There again are four major components of hemostasis. We have our vascular system, we have our platelets, or sometimes called thrombocytes, our coagulation factors that we talked about during our secondary hemostasis unit, and then fibrinolysis and ultimate tissue repair. So again, those are the major components. Today we're going to talk quite a bit about the vascular system and some platelets. Excuse me. In order for us to maintain successful hemostasis, there is a process that must occur. Initially, when we have a site of injury, vasoconstriction of the blood vessels surrounding the injury will occur. This is to divert blood flow away from the site of injury to kind of try to minimize bleeding. We then have formation of the platelet plug through primary hemostasis, which is what we're going to talk primarily about today. We've already talked about the initiation of the coagulation cascade during our hemostasis lecture. And as we know, the endpoint of that secondary phase of hemostasis, we end up with a nicely polymerized platelet, stable platelet plug or clot. Thank you, factor 13. But we haven't really we haven't really talked about what happens after the clot is formed. So fibrinolytic removal of excess hemostatic material is going to help, number one, maintain your vascular integrity. So the site of injury is going to heal, and as it's healing, removal of those clot byproducts are going to be removed. But something else that our fibrinolytic system does is it regulates our coagulation system. So there always has to be some form of checks and balances. That way we don't become too thrombotic or hypercoagulated. And we really have to just keep everything in check. So we'll talk about some of the wily ones as we move forward, but there are a couple of them who like to get into trouble. So the areas of vasoconstriction that we're first going to see at the site of injury are going to involve our blood vasculature. So arteries, veins, those are usually larger and deeper. Arterioles and venules are a little smaller. And then capillaries are the very smallest vessel that we have. Let's take a quick trip down memory lane to the old anatomy and physiology classes that we all loved. Arteries and veins, as you may recall, are the largest vessels in the body. Arteries are the distributing vessels that leave the heart, and they have the thickest walls of the whole vascular system. Veins, on the other hand, are the collecting vessels that return blood to the heart. Veins are typically larger and have a more irregular lumen than arteries, but they have thinner walls. These injuries to arteries or veins are usually much more serious and emergent than some of our smaller vessels. So if we have sites of injuries that are associated with our arteries and our veins, we might be at big risk for hemorrhage. And even though these vasoconstrictions do occur, these are larger veins and arteries, these are larger vessels, and so vasoconstriction simply would not be enough in the case of a large artery or vein. So if we were to follow an artery all the way out to the extremities, we would see arterioles that are really just microscopic continuation of arteries. And they give off branches called meta-arteries, which then turn to join the capillaries. And the same could be said for the venules, which are microscopically sized veins, and they connect to the capillaries as well. So if you can picture your little capillaries where they have incoming oxygenated blood and outgoing deoxygenated blood, I bet we can all pull up some kind of memory of a capillary in our mind with half of it being red and half of it being blue. I'm tempted to put a picture in here. So of course capillaries are the thinnest walled and the most numerous of the blood vessels. They are the ones that are also closest to the surface of our skin and are most often the sites of injury for minor scrapes and cuts and bruises. So think of a paper clip. You might get a paper clip and it barely even bleeds because those capillaries are so small. The blood passes from the arterial to the venous system via capillaries, and then they are composed of a single layer of endothelial cells. So really just one single layer of endothelial cells. And because they are so small, and because that vasoconstriction is very, very efficient in the case of these small capillaries, we don't even actually have to activate the coagulation cascade. So vasoconstriction in this case is actually enough. We might be able to, we might have a few platelets come together to form a rudimentary clot, but we wouldn't really need to activate that coag cascade. It would just be such a small and minor thing. So think of a paper cut, unless you're on some kind of blood thinning medications where, you have hypercoagulability. Capillaries do not need to do have the activation of the coag cascade. Our vascular physiology is going to play an important role in hemostasis. Primarily the role of that vasoconstriction, which we've already talked about a little bit, the role of the endothelium, and then maintenance of vascular integrity. I'm sure all of you know what the meaning of vasoconstriction means, but just in case you've forgotten, let's just recap what exactly is happening with vasoconstriction in hemostasis. So when a smaller vessel, such as an arterial, venule, or capillary is injured, so we've gotten a cut, a contraction occurs to control bleeding, and this contraction of the blood vessel wall is called vasoconstriction. It's a short-lived reflex, and it's produced by the sympathetic branches of the autonomic nervous system. So this happens without us ever thinking about it. It is a protective mechanism to divert blood away from the site of injury. The next major player who has a role in primary hemostasis is the endothelium. The endothelium contains connective tissue such as collagen and elastin. And if you think back to your coag cascade, you've got high molecular weight kininogen, and you've got some prekallikrein. And then as it comes down into that little loop into where your intrinsic factors start, there's a little blip about collagen. And this is kind of in that place where collagen really makes its appearance. And that, of course, is because once there is an injury, collagen is exposed and all sorts of things happen. The endothelium is also involved in the clotting process by producing or storing clotting components. Believe it or not, not all of our coag factors are just in circulation. Some of them are actually hiding out and hanging out in that endothelium, waiting for their need, like the need to arise for their activity. It's also rich with plasminogen activators. So we haven't talked much about plasminogen or plasminogen activators, but plasminogen activator is going to activate the primary fibrinolytic regulator. So it will activate plasminogen to plasmin, and plasmin will help regulate the amount of fibrinogen and fibrin that is circulating and kind of keep us from being hypercoagulable. If appropriately stimulated, that plasminogen activator is released and activates plasminogen, and that ensures that rapid lysis of fibrin clots. So not only are we initiating clotting, we're also regulating. So see how those checks and balances are so important. So the endothelium has, has a game plan. I'm going to look, I know we've been injured. We're going to release these important components. We're going to expose our collagen to stimulate activation of clotting, but we're also going to release the tissue plasma or the plasminogen activator so that we don't get things out of control. All right. Once we have disruption of that endothelium, it directly activates all 4 components of hemostasis. So interesting, right? So after this event, the following events take place. Rapid vasoconstriction for up to 30 minutes, which reduces the blood flow and promotes contact activation of platelets and coagulation factors. So primary and secondary hemostasis. And then in the second phase, the platelets adhere immediately to that subendothelial that's been exposed, that connective tissue, particularly collagen. And if you think back, or maybe jumping forward a little bit, collagen is one of the agonists that we use in platelet aggregation studies. So keep that in mind as we're moving forward and talking more about that. In the third phase, coagulation is initiated through both the intrinsic and the extrinsic pathways. And then finally, fibrinolysis occurs following the release of that tissue plasminogen activator from the vessel wall. So everything is going on. We've got vasoconstriction, activation of platelets, activation of the secondary hemostasis in terms of our coag cascade, and fibrinolysis. So this is how we maintain hemostasis. We stop the bleeding, but we also regulate the bleeding so that it doesn't get out of control. As wonderful as our blood vessels are, carrying our blood around, keeping us from hemorrhaging, there are a few things that we need to maintain our vascular integrity. So vascular integrity, or the resistance to vessel disruption, requires 3 essential factors. And without, if one of these 3 factors are missing, we would be at a higher risk for vessel disruption. And when I say vessel disruption, I mean things like rupture, easy injury, fragility, all of those things. So let's talk about what the things are that we need. Very first thing we need are circulating functional platelets. We need enough platelets and we need them to function properly. When we have things like platelet disorders or decreased platelets, we run into problems with regard to hemostasis. Another thing that we need, and I don't really need you to know all of the pathophysiological processes of the adrenocorticosteroids, but they are particularly important, especially glucocorticoids. They're crucial for maintaining vascular integrity and function, and one of the reasons for that is that they help modulate vasoconstriction. They essentially enhance the sensitivity of vascular smooth muscles to vasoconstrictor hormones like adrenaline and angiotensin. So they also help regulate vasodilation, which helps open up. So it's the opposite of vasoconstriction. Without that critical balance, we would not be able to have the flexibility, the function that our vessels have. And then last but not least, ascorbic acid. This is vitamin C. Vitamin C is really important to maintain that as well. So, a lack of any one of these factors produces fragility in the vessels, which makes them prone to disruption. Like we said earlier, healthy diet, adrenocorticosteroids, and circulating platelet and functional platelets. The megakaryocyte. You guys might remember the megakaryocyte from our red blood cell unit and our white blood cell unit. Obviously, we want to kind of be familiar or refamiliarize ourselves with the megakaryocytic cell series. Sometimes I feel like it gets put on the back burner until coagulation unit comes around. But let's talk a little bit about it and do a refresh. So we want to talk about our general characteristics of the megakaryocytic development, the developmental sequences of the platelets. We want to talk about cellular ultrastructure of a mature platelet and platelet kinetics, lifespan, and normal values. So remember, this in this picture is a megakaryocyte. Usually we see these in the bone marrow, and then the platelets actually break off as little pieces from this cytoplasm, that granular cytoplasm. Let's take a look at our next slide. You may remember the phases of development, cellular development from our red blood cell and white blood cell unit. And here we are yet again with the megakaryocyte. I feel like we did kind of skim over it initially. So some of the general characteristics of megakaryocytes, of course, are going to start in that megakaryoblast phase, moving on to that pro-megakaryocyte, and then megakaryocyte, and then last but not least, these little tiny platelets will break off from the cytoplasm of that megakaryocyte and go into circulation. So these mature platelets, sometimes called thrombocytes, are metabolically, active cell fragments and are the second critical component in the maintenance of hemostasis. These anuclear cells circulate in the peripheral blood after being produced from the cytoplasm of bone marrow megakaryocytes, the largest cells found in the bone marrow. And are they? They really are. They're gigantic. Let's look at the ultrastructure of a mature platelet. So essentially, we're going to look at the anatomy of a platelet. Examination of a plate with an electron microscope reveals a variety of structures that we can't see under the regular microscope. These structures are fundamental to the functioning of the platelet. So remember, circulating functional platelet is one of the very important things for maintaining vascular integrity, but also maintaining hemostasis. So the first area that we're going to look at is the glycocalyx. Then we have the cytoplasmic membrane, microfilaments and microtubules, and the granules. This picture shows some of the contents within those granules, which will come into play a little bit later in terms of our aggregation, platelet aggregation and function. Let's look at the next picture. I feel like it's a little bit better. This kind of looks like something from 1985 that came from like a rudimentary computer program. But it's a fantastic picture with regard to showing you what's in the granules. So don't get me wrong, newer is not always better. It's true that I did say newer is not always better, but I have to tell you this picture is newer and better, especially with regard to the representation of that glycocalyx. That glycocalyx on the platelet is kind of a fluffy coat. Think of like one of those puff coats. It's comprised of plasma proteins. It's composed of plasma proteins and carbohydrates that are related to coagulation, complement, and fibrinolytic systems. And it's also the characteristic that give platelets that kind of lacy look around the edge of the periphery when we're looking at it in a microscope. Glycoprotein receptors on the glycocalyx mediate platelet adhesion. So platelets don't have, oh shoot, what do you call it? Velcro, sorry. They don't have Velcro. They don't just magically adhere. There has to be something, some point of connection where they can really hang on to that. And one of those is going to be associated with our von Willebrand factor. We'll talk more about that here in just a minute, but it's going to be really important for that adhesion and then the shape change and aggregation as well. But before we get to the platelet function and all of the fun that it's about to have, let's talk about the anatomy of the platelet. The first area of anatomy is called the peripheral zone, and that's going to control adhesion and aggregation. The peripheral zone contains a variety of proteins, including membrane glycoproteins, like the ones we were just talking about on the glycocalyx. And these are receptors that aid in transmitting stimuli across the platelet surface. For example, glycoprotein 1b interacts with von Willebrand factor to facilitate platelet adhesion to that subendothelium. So think of von Willebrand factor as the glue that holds that platelet to the site of injury. But something else has to happen for platelets to get to where they need to go and to, do their job. And we have what's called the structural zone, and that is going to control shape change. You may look back at that kind of rudimentary picture that we looked at earlier, but microtubules and microfilaments, which are usually soft and gelatinous, once they are stimulated, they contract and it changes the shape almost instantly. And then we have the last zone. This is the organelle zone, and this is going to be very, very important with regard to platelet function as well. So there is going to be storage and secretion of substances from the granules. So we have dense granules and we have alpha granules in that organelle zone. Let's talk about the platelets granules. We've got a few different things going on. The first type of granule are alpha granules. These are heparin neutralizing platelet factor 4, beta thromboglobulin, platelet derived growth factor, platelet fibrinogen, fibronectin, von Willebrand factor, and thrombospondin. So all of those proteins are found within those alpha granules. Now look, if you see von Willebrand factor is in there, we've got platelet fibrinogen, we have all sorts of things in there that are going to really kind of wake us up. Next, we have the dense or the delta granules, and these are going to have things like serotonin, adenosine diphosphate, also known as ADP, adenosine triphosphate, ATP, and calcium. And we know that some of serotonin can be a kind of like a hormonal stimulant. Adenosine diphosphate is one of our components in terms of one of our agonists for platelet aggregation. And calcium is also one of the important cofactors that we have in our coagulation cascade. Platelets also have lysosomes. Now, lysosomes occur in a lot of different granulocytes, but in this case, these lysosomes are storing hydrolase enzymes. And if you think about the coagulation cascade, it is typically an enzymatic reaction or cascade that necessitates that cleaving. And hydrolases constitute a class of enzymes that commonly function as like a biochemical catalyst that use water to break a chemical bond. And so that's where that cleaving action comes to facilitate that coagulation cascade through enzymatic reactions. So that's going to be really important in terms of starting the process of coagulation as well. The next thing I want to talk about is the dense tubular system. Now, there are a couple of hormones and chemical compounds that regulate platelet response. And one of those is prostaglandin, and the other is thromboxane. And we have a substance called arachidonic acid, and that's a substance used for prostaglandin and thromboxane synthesis. Now, if we don't have arachidonic acid, or if arachidonic acid is in short supply, we can't activate or we utilize it as a substrate for prostaglandin and thromboxane, which means our platelets will go unregulated. So when a platelet is stimulated, arachidonic acid, cannot speak today, I'm so sorry, arachidonic acid is cleaved from that membrane of phosphoglycerides by the enzyme cyclooxygenase, forms thromboxane A2. So thromboxane A2 is really what we're after because thromboxane A2 causes platelets to aggregate and induces that release reaction that we're seeing when they release those contents of their granules. Now, there is something that probably every household has that irreversibly activates the cyclooxygenase enzyme in platelets, which prevents aggregation from occurring, because without that cyclooxygenase, we cannot form our thromboxane A2. And thromboxane A2, of course, is what causes those platelets to aggregate and secrete their platelet granules. And that is aspirin. Aspirin irreversibly inactivates that cyclooxygenase enzyme in platelets for the remainder of their lifespan. Now, it's true we will produce other platelets that are functioning because they haven't been inactivated with that aspirin, but if you take aspirin every single day in high doses, you might have some platelet problems. It's not that you don't have enough platelets or that they started out dysfunctional, but you may have a platelet function disorder due to aspirin use. Now, that's okay because it's not okay if you have a platelet disorder, but I'm saying aspirin actually can be used therapeutically. Not so much as like an anticoagulant per se, but there are some conditions such as people who have a history of heart attack, stroke, that they could take a very small dose of aspirin every day to basically inactivate some of their platelets, but not all of them, so that they have a decreased risk of thrombosis. Some of the information on this slide you may already know, and some of it may be new to you. So let's just take a quick look at platelet kinetics, lifespan, and normal values for our platelet count. An average megakaryocyte produces about 2,000 to 4,000 platelets. That's a lot of platelets. The maturation period for the megakaryocyte in the bone marrow during its phases of development is approximately 5 days. So it turns out pretty fast. And if you think about how many platelets we have, that might be part of the reason. Platelets initially enter the spleen once they're released from the bone marrow, where they remain for 2 days, about 2 days. And then following this period, platelets are either sent out into circulating blood, or they remain as part of the splenic platelet pool. And those are, of course, sequestered there in case of an urgent need, and if something were to happen and an increased need for platelets were to arise, they would be there waiting as backup. Now, at all times, there's approximately 2/3 of the total number of platelets that are in systemic circulation, and then about 1/3 of them exist in that pool of platelets in the spleen waiting to be back up if needed. Normal platelet range, I'm sure you guys remember this, is 140 to 400 times 10 to the third microliters. And the average lifespan of a mature platelet is 8 to 12 days, so not long at all, which can explain why Number one, megakaryocytes are so large, why they produce so many platelets, and if you only live to be 8 to 12 days and you spend 2 days initially there, that only gives you about a week or so in circulation before your lifespan has come to an end. Now that we've talked about the importance of platelets, kind of what their anatomy looks like, and their lifespan and kinetics, let's talk about the overall function of platelets. Because remember, we need to have enough platelets, but we also have to have enough functional platelets. So let's see how normal function should occur. Following damage to the endothelium, so site of injury, of a blood vessel, a series of events occur, including adhesion to the injured vessel, shape change, aggregation, and secretion of those granules. And there are specific agonists that lead to that platelet activation, and they're varied and kind of include a few different things. We mentioned ADP, thromboxane A2. There's a platelet activating factor. I know we just talked a little bit about collagen as an agonist, but also thrombin. So if you think all the way down to your common pathway where we've got prothrombin and is converted into thrombin, thrombin does a lot of important things, and we kind of talked about that in our secondary hemostasis lectures as well. And one of the things that it does do is it activates platelets. It helps activate platelets. Thrombin does all things. We know that there are different actions that have to occur before a successful platelet plug formation can occur. And we've mentioned them: adhesion, shape change, aggregation, secretion, etc. But what exactly is happening during each step? So let's break it down. With regard to adhesion, that subendothelial collagen interacts with platelet glycoproteins on that glycocalyx, or that fluffy coat, when they come into contact with it. So those are going to be contact activation. And von Willebrand acts as a bridge between the platelet and the tissue in this process. Now, this is completely reversible if you were to disrupt it, or disrupt that rudimentary formation or adhesion. It could just fall off. It wouldn't really be stable in any way. What about shape change? Once the platelet is stimulated, it transforms from a discoid shape into a spherical shape with kind of like spiny projections. So it gets a little prickly looking. After that, we have aggregation. And that's really where more and more platelets arrive, and the process where platelets start to attach to each other. Now, this does require calcium and fibrinogen. It's represented by the primary wave of aggregation, but it is also a reversible process. For example, if we were in hematology today and I ran a CBC and our instrument flagged for platelet clumps, I could vortex that and it would release the aggregation, it would inactivate the platelets, and they would all kind of just go back as long as no fibrin has been formed. That's why we look for fibrin when we're looking at the feathered edge, if we suspect that there's been any clotting to occur. Once fibrin has been formed, no bueno. And that's because of secretion or the release reaction. So the substances from those platelet granules are released, and that represents a secondary wave of aggregation. Now, this requires energy, and it is irreversible. So if you think about having a bag of sand, and you're carrying around this bag of sand, you stick it on you've got it all closed up, you've got it in a pocket, and then, as you're walking, it kind of hitting your leg, and you pick it up and it's kind of squishy like a bean bag. You can change its shape. You can throw it up in the air and it lands with the other sand, but it's all contained. Once you open that bag of sand and you let out all of the contents, you cannot put every grain of sand back. It is irreversible, and it cannot be undone. And that's kind of the same idea with secretion. Once that release reaction occurs, all of those substances are released, and we call that the secondary wave of aggregation. And at that point, we have a primary hemostatic plug formation. Fibrin is incorporated into that those aggregated platelets to form a plug. But we're not done because, as you know, we need to stabilize that plug. And of course, that is done through the coagulation cascade in our secondary hemostasis that we've already talked about. Let's take a look to see exactly what's happening in this next slide. So if you take a look at this picture, this first over to the left, we have the subendothelium, and right in the center, about 3/4 of the way of this across, we've got kind of an opening where it's showing exposure to collagen. So that's collagen, that's supposed to be our endothelium or our subendothelium. And then we have an inactive platelet with granules. We've got that GP1B receptor, and then we've got the 3 little green balls that represents von Willebrand. So that's the glue that helps hold the platelet on with adhesion. And then we have the alpha 2 and beta 1 receptors, which are part of our contact with collagen, which activates it into this conformational shape change. And now it's activated and goes along, and now von Willebrand is released. We have more platelets recruited, and now we've released our granules. And those granules are actually the agonists, some of the agonists that recruit new platelets. Then they start to stick together. And then we've got these fibrinogen bridges that form, and here are some more platelet. Do you see the little yellow platelet receptors that have that fibrinogen coming across? And then we'll get fibrin, and we will have that factor 13 coming in, make our stable clot. Now that we have kind of a general idea about what platelets look like, how long they live, what their job is, what's happening when they are activated, the question is, how do we measure if our platelets are working? Because platelets are a fundamental part of coagulation. So laboratory assessments of platelets kind of have a few different routes that we can take. The very first, I would say, is the platelet count. It's a fundamental component in the evaluation of a patient, and we simply get that with our regular, ordinary, everyday CBC. We can also examine the peripheral blood smear for platelet count and also for morphology. So if our platelet count is normal, but our morphology is not, we might have to verify that through visualizing them on the slide. And then we do have some qualitative platelet abnormality tests, including things like bleeding time, which we don't use too often anymore. It used to be kind of an antiquated test. Clot retraction, PFA 100, and then platelet aggregation, and sometimes secretion. Excuse me. We used to do the secretions here, but now we send them out to a reference lab. Okay, so qualitative assessments of platelets. If a platelet count is normal, but a patient has a suggestive bleeding history, an assessment of platelet function should be conducted. So we know even if we have enough platelets, we just need to make sure that they're functioning properly. And these methods would include aggregating agents and Lumi aggregation, which is going to be our platelet aggregation and secretion. Here are a couple of other things that we can use with regard to laboratory assessment of platelet function. I'm not going to read them all through, but take a look, and as we go forward, come back to the slide and see if you can identify where each one of these are going to come into play. The first platelet assessment that we are going to talk about is the bleeding time. Now, this is pretty antiquated. It's not one that we use very frequently anymore. We have other methodologies that have replaced it essentially. But if you think about it, this is kind of an ingenious test. A long time ago, we didn't have the same type of technology and methodologies that we have now. And if you suspected that a patient had a bleeding disorder, well, what better way to measure it than to make a superficial injury and time, the amount of time that it takes for that patient to clot or stop bleeding? I mean, kind of makes sense, right? Bleeding time is an infrequently performed test, like I said, and in vivo measurement of vascular integrity and platelet plug integrity is really kind of the aim. We want to know how well you stop bleeding, how long it takes you to stop bleeding, etc. Now, thrombocytopenia can affect both the bleeding time as well as platelet function. So if we have too few platelets, they may be functioning all right, but there are just too few of them and we can't measure it appropriately because the number is abnormal. The way we perform the bleeding time is we make a small superficial wound and then of course just monitor the time for the bleeding to stop. There are two different methods. Initially, we've got the Duke, which is like a little superficial wound on your earlobe, or the IV method, which is a forearm where you have a blood pressure cuff above, and then they make an injury, like a little superficial injury on your forearm, and then see how long it takes to stop. Another kind of antiquated test that we look at for evaluation of coagulation is clot retraction. Now, because platelets have that ability to kind of change shape, they also have what are called contractile abilities. That contractile ability that platelets have also results in the contraction of formed clots. So once platelets come together, they've gone through a shape change, they have their fibrin crosslinks, and they are now a stabilized clot. Because of that contractibility, as the time goes on, that clot is going to kind of like shrink. And you can see in the two tubes to the right, that is a proper clot retraction. The two tubes on the left, it doesn't look like there's any clot retraction happening there. So what clot retraction reflects are the number and quality of platelets, fibrinogen concentration, fibrinolytic activity, and packed red cell volume. So if you think about it, if you don't have a lot of red cells, you're not going to have a very big clot, right? So the degree of clot retraction is directly proportional to the number of platelets and inversely proportional to the amount of fibrinogen. We see an abnormal clot retraction pattern in Glanzmann's thrombasthenia, and we're going to talk more about platelet disorders in our next lecture. So I'm just bringing it up early so you can kind of see the picture that goes along with that, but keep that in mind. The most commonly utilized platelet function screening test is the platelet function assay, also known as the PFA 100. It's a relatively new screening test for platelet function. And again, it's just a screening test. It doesn't give us really too much information other than is clotting time normal. But it has replaced that bleeding time. Platelet function is tested by using cartridges that are collagen coated. They have like a little membrane in them that are collagen coated. And remember, collagen helps with activation of platelets. And then we have two agonists that we use. We use ADP in one cartridge and epinephrine in the second cartridge. This essentially stimulates the in vivo processes that platelet adhesion and aggregation demonstrate. following vascular injury. So on the left of this picture, you see what an actual patient injury would look like. And here we artificially induce that same process. And what we are looking for is the amount of time that it takes for a clot to close this aperture between both sides of the collagen membrane. And then last but not least, if we do have a PFA that we perform and it comes back as abnormal aggregation or platelet function, so to speak, we would then go on at the physician's request to perform a platelet aggregation. Now, I actually really think platelet aggregations are so neat to perform. They're very time consuming, so everyone's kind of like dreads when they come in because they just take up your whole day, or they can in some cases. But ultimately, what we do is we spin the sample down and we take platelet-rich plasma. We want just the platelets. We don't want the cellular components outside of the platelets, though. And we stimulate them in various cuvettes with agonists, ADP, collagen, arachidonic acid, and ristocetin. And if the physician requests, we can also use epinephrine. Now, we use this platelet-rich plasma, and we add it to these little glass cuvettes. And once they are added to the agonists are added to the platelets, we can actually watch them in real time and see the response in a spectrophotometrically measured chart or graph. So to the left over here, and I think in our next lecture we have a better picture, but here we've got each line represents a different agonist. One is ADP, collagen, arachidonic acid, and ristocetin. And you can kind of see the platelets aggregate in response to the agonist. And it's very cool too, because when you pull the little cuvettes, they're just little glass cuvettes. When you pull them out of the instrument once you're done testing, you can macroscopically see the little platelets that have aggregated together in these little clusters, and it's just neat. It's really neat. The first time you ever do a platelet aggregation, which you won't as a student, but you could watch one if we get one while you're on the bench as a student. But it's just very neat. All right. Most abnormalities that are found in our platelet aggregation study are acquired, and it's either going to be due to aspirin or undisclosed therapeutic anticoagulant use. We can also order a platelet secretion test, which will test the release reaction of the granule contents. We used to do that here. Again, we don't do it here anymore, but I mean, it's kind of a neat, it would be kind of neat to be able to see all of those agonists released, or at least the contents of those granules, to see, is it an aggregation issue? Is it a release issue? What's going on? Anyway, that wraps it up for our introduction to secondary hemostasis. We will continue on with our recap and our platelet disorder lecture. See you soon.